And next, I'm going to invite one special person from DOS, Professor Kirti Singh ma'am. And ma'am is an excellent glaucoma surgeon and most importantly an excellent teacher. So ma'am is going to speak about malignant glaucoma, different strokes. Welcome ma'am.
Thank you so much for your kind words. So I'll be talking about malignant glaucoma, some different strokes which we faced, which caused diagnostic dilemmas. So we do know that malignant glaucoma, described by von Greffe incidentally 1869, or the aqueous misdirection, has elevated IOP despite more than one patent PIs as a definition. It can be spontaneous, but it is invariably after incisional surgery. It could be cataract, glaucoma, pars plana vitrectomy, buckling, YAG PI, suturolysis, or post-biotic use. And out of these, the predisposing factors are Asian ethnicity, females, ACG, short axil length, and fellow eyes. And by chance, the two cases I'll be showing will have all these propensities, but with a difference. So the case one was a 29-year-old male student. He complained of decreased vision for distance and near in the right eye. Left eye already he had lost vision for a year. He had consulted elsewhere who diagnosed glaucoma and started on medicines. He was on 2 anti-glaucoma medications. He had a positive family history in the grandmother who had glaucoma. Now, when we saw the patient, we thought this was a juvenile open-angle glaucoma because 29-year-old. Incidentally, I don't know how many of you we are seeing early onset angle closure glaucoma now. So this was another one of that child who had angle closure glaucoma and the poor vision with definite pupil rough atrophy with the patent PIs and shallow anterior chamber. The pressures were very high at 34 and 32 despite medical management, and so he was taken up further, and the gonioscopy confirmed the closed angles with goniosynechia. The disc size was average sized with a DDLS of 7 to 8 and a cupping of 0.9. The right eye had a macular split, and the left eye, the vision was so poor that the fields could not be done. So we planned treatment on the sequential trabeculectomy was planned. Oral AGMs was started. Now on first week post-op, he complained again of decreased vision. Now, this was the only seeing eye he was dependent on. So, he complained of sudden decreased vision again. The vision had dropped to hand movements. The bleb was not overfiltering, but the AC was diffusely shallow. PI was patent, and the lens was bulging. But the IOP was very low at 4 millimeters of mercury, literally not regardable. So we looked out for coral attachment. It wasn't there. On the UBM, there was no ciliary wall rotation evident, and B scan confirmed that there was no CDs. So there was a diagnostic dilemma, and we found to our surprise that there were hypotenuse malignant glaucoma described. So that is what we diagnosed, and surprisingly, the other eye, which had the surgery done later, after releasable suture removal, again that eye also had a shallow AC. But here the IOP remained high, and here the UBM did show ciliary rotation. So the diagnosis of malignant glaucoma hypotenuse in one eye and malignant glaucoma hypertenuse in the other eye. So as the treatment described has been cycloplegics and YAG laser and Chandler, we did the same things. We did cycloplegics and topical steroids. We did the AC reformation with viscoelastic. We went by the book, and then we did the Chandler's procedure. After that, the treatment worked, the vision came back, AC became formed, and the pressures increased to 10 millimeters. On the follow-up, since he required atroponization, this patient couldn't see his mobile phone or anything, so he stopped using atropine. And because of the stopping of atropine, again the pressures came to 14, but the AC shallowed and the vision dropped. So we have two eyes, one behaving with hypotenuse malignant glaucoma and the other hypertensive malignant glaucoma. Now, over a 2.5-year follow-up, the bleb is maintained, but the patient requires atropine. We are trying to convince him for a lens extraction, but he's not being convinced. So the second case is a 75-year-old female. She had advanced BACG again. Right eye, a trab had been done 10 years ago, and left eye, a phaco trab had been done. She had significant cataract, so we took her up for a phaco, which was uneventful. After 3 months, she came with recurrent episodes of shallow AC and IOP spikes, and the presenting feature was not pain, the presenting feature was myopia. She was treated with atoponization, and again we did the whole Chandler's procedure, everything, but here nothing worked. And after the fourth episode, the bleb was shallow, the PI was updrawn regarding needling. We did a YAG hyaldotomy and a capsulotomy. Then we went ahead and thought that we'll do a pastona vitrectomy. So it worked for a couple of weeks, but then again the myopia and the shallow AC occurred. So ultimately, finally, we did an iodozoinlo hyalodovitrectomy, and since then she has been fine, and this patient did not require atroponization. So IZHB was the solution, and the other eye which had the phaco trab done has been stable since 2014. So again, we have two different manifestations in two different eyes. So to summarize, variable presentations of aqueous misdirection, angle closure is a known risk factor. One was a young boy with normal IOP, and the fellow eye was high IOP. One was an elderly lady with multiple episodes of high IOP with a presenting feature of myopia and shallow AC. The triggers were trabeculectomy, cataract surgery, and releasable suture removal. Lessons learned was that IOP could be a confounding factor. Sequential management strategy works in most. Fellow eye is predisposed, and recalcitrant traces do require IZHV, and lifelong cycloplegia may be needed. So we leave you with this message of nature, which looks like a question mark to me at least, that the malignant glaucoma is still manifests in different ways, and this was one of the third cases reported. We sent it for publication of hypertonous malignant glaucoma. Thank you.